As was mentioned, I'm from Seattle. I'm bringing you a few slides from Seattle just to, I know London's a very cultural and artistic place. We have a great glass artist in Seattle, Dale Chihuly, who happens to be a friend for 30 years and a patient. So he has a wonderful installation at the Seattle Center, and I thought I'd bring a few photos of Dale's installation to get us off of teeth part of the time. I'm going the other direction in terms of the types of things I'll be showing you for the next hour and a half. And that we're going to be talking about what I think are some of the most challenging patients in any dental practice. You know, I've been involved in education well over 30 years. I've done workshops on care planning. We used to call it treatment planning, but I just learned it's care planning. Treatment planning workshops for the last 30-some years where students bring cases with them. Now we do it in Scottsdale, Arizona at Spear Education. All our workshops are done there. And the cases we're going to be talking about are by far the most common cases that dentists bring. And we're going to talk about 4 very specific types of patients. So we're going to look at patients that have deep overbites without any tooth wear, but these patients often don't like the aesthetics of their smile. So we're going to talk about how does one go about managing patients who might want to look better, but in fact have this occlusal relationship. We're going to be talking about patients that have deep overbites and a very specific pattern of wear. We're going to call it pathway wear. You can imagine how difficult it would be to try and restore those lower anteriors. And you can also imagine what the lingual of the upper anteriors look like because they're in occlusion with those lower anteriors. We're going to talk about patients with anterior open bites and posterior wear because it is not at all uncommon if a patient has an anterior open bite that they will wear out their posterior teeth. And we're going to talk about these patients, patients who have end-to-end occlusions and tooth wear. So basically, we have 4 types of patients we're going to be talking about. Deep overbites without wear, deep overbites with wear, anterior open bites with posterior wear, and patients with significant anterior wear and end-to-end occlusions. So the question that usually comes up when I talk to students is, if this is the patient and they walk into your operatory and you meet them for the very first time, where do you start? And the obvious answer is you do an examination. And typically what happens in that examination is you see the patient and you recognize that this is really complicated. And so you don't want the patient to think you don't know what to do. And so in my experience, when dentists aren't sure what to do, where do they start? They get study models, which allows you to sit at your desk in privacy and not know what to do, right? I mean, who do you make alginate impressions on? Unless you're going to be making bite guards or bleach trays, you make alginate impressions on people you don't know what to do with. And so you make a set of study models on this person. And now you go sit at your desk quietly, and you study the models, and you still have no idea what to do. So you think to yourself, you know, I've taken a bunch of occlusion courses. What I really need is I need mounted models. So I do a face bow and I do bite records and an articulator and I mount everything. And now I'm sitting at my desk quietly looking at my mounted models and I still don't know what to do. So I'm going to suggest to you that anytime you make alginate impressions because you don't know what to do, the reason you don't know what to do is the teeth, gingiva, bone, or occlusal relationships are incorrect. They're in the wrong place. And when teeth are in the wrong place, dentists don't know what to do. Dentists never make alginate impressions to treat a patient who has well-aligned teeth, healthy gingiva, and perfect occlusion. You treat teeth. The kinds of folks we're talking about, you can't do that. So what's the first thing we have to realize about these 4 cases we're going to be talking about? Deep overbites without wear, deep overbites with wear, anterior open bites with posterior wear, end-to-end occlusions with wear. The first thing we have to do is we have to learn where to put the teeth. And guess what? Models do not help you with where to put the teeth. They don't. Whether they're handheld models or they're mounted models, they teach you nothing about where to place teeth. You might just as well be looking at an edentulous arch and asking yourself from looking at a set of mounted models of edentulous arches where the teeth go. You have no idea. So what we need when we start talking about these kinds of patients is we have to have a reference. You may think that's what you should do. You look at those teeth and you say to yourself, well, the central incisors are 4.5 millimeters long. A normal central's 10.5, 11. Maybe I should add 7 millimeters to the centrals, open the bite, and your brain can see it. You can actually see the lab starting to wax it up. But you could be completely wrong. Because in fact, it may be that, as teeth wear, they erupt. And what may be correct is actually the teeth should be there. And you may not have to change the maxillary posterior teeth at all, but you have no way of knowing that. So my first lesson for you on all of the complex cases you have in your practice, every dentist I know has a set of models on their desk that they look at periodically and go, I still don't know what to do, and then they put them back down. The next time you pick up those models, what I'm going to suggest to you is the first thing you have to do is answer the question, where should the teeth go? Starting with the maxillary teeth. Starting with the maxillary central incisors, just like a denture. Because until you establish maxillary tooth position, you cannot develop the occlusion. So where do we start? How do we know where to place teeth? We need a face. We need lips. We need something to tell us what to do with those worn teeth. Whether we should lengthen them, how much we should lengthen them, whether we should change the gingival levels, how much we should change the gingival levels. Models will never tell us that. Whether they're handheld models or mounted models, they will never tell us that. So we have to have this information. His lip at rest. His teeth are 7 millimeters short of showing. Normally, we would like to see at least a little bit of the centrals. That means we're going to have to add 7 millimeters to those teeth. His lip moves roughly 7 or 8 millimeters, which is quite normal. So in reality, for this patient, he is a patient where that's the wax up that was done. His bite was opened. He did have 7 millimeters added, but the models taught us none of that. What taught us all of that was his face. So that's my first rule for you on all of these complex cases, is we have to understand that tooth position is always the starting point. In the planning process, not in the sequence of treating necessarily, but in the planning process. Now, the term that we use, that we use in Scottsdale at Spear Education, I've been using it since 1986, and I call it facially generated treatment planning. It's a very simple concept. It simply references the fact that we have to plan treatment starting with tooth position, and that means we have to start with the face and the lips and work our way in. Effectively, the way I teach treatment planning is very simple. I think of treatment planning as 4 separate components: an aesthetic component, a functional occlusal component, a structural component, and a biologic component. Dental school teaches us mostly biology and structure, which is what we need as practicing dentists. But when we plan patients with complex problems, we have to plan tooth position, gingival levels, and papilla levels first in the maxillary arch. We have to establish what our target is for the maxillary arch. Once we establish what the target is for the maxillary arch, we can now do occlusion, because the maxillary arch tells us what we need to do to the mandibular teeth to make the occlusion work. Once we know those 2 things, we've now identified tooth position and tissue levels for both arches. Now we can decide how we will restore, which teeth we will restore, do we do ortho instead, which teeth do we replace, which teeth might need endo, perio, oral surgery, and in the world of 2016, in biology, we also have airway issues that we have to consider. So when I plan treatment, we always plan aesthetics first, occlusion second, restoration third, and then what we need to do to accomplish all that biologically fourth. That is not the order in which we treat the patient. You can imagine that if we have biologic issues, we have to treat the biologic issues first. But when we plan patients with complex problems, complex tooth position problems, if you try and treatment plan them in a traditional model of looking at a tooth, you will never get a treatment plan because the teeth are in the wrong place. Now, really what happens is essentially this. You do an exam on your patient. Here's what you're used to doing. You identify the problems, caries being a problem, periodontal disease, missing teeth, etc. And then what do? You come up with what you want to do for the patient. The difference between your routine approach and the kinds of patients we're talking about is after you've identified the problems, you don't get to try and think about treatment. Instead, you have to add a new step in there. You have to identify the desired outcome for the patient. Tooth position, tissue levels, papilla levels, occlusion. Once you've identified those things, because those are what's wrong, that's why you did the study models and that's why you're confused, once you do those steps, now you can identify how you'll treat the patient. Now, bottom line, we're going to be going through a lot of cases in the next hour. But I want to make it clear that there's some things that come from the examination that we have to manage before we ever even think about doing what I'm going to be showing you in terms of the planning process. So the first thing is, if your examination finds infections, pain, or deep caries, you're not going to be going forward with complex treatment planning until you manage those areas, right? So that's quite obvious, I hope. Next thing we have to do, we have to recognize that in order to do the planning process that we're going to be talking about, we have to be able to have a set of mounted models. And that means patients who have joint problems or muscle problems, those issues have to be dealt with so that you can, in fact, identify and get a repeatable position to mount models at, because you need the mounted models to go through the steps that we're going to be going through on all of these cases. All right? There are going to be some findings from the exam that actually alter your treatment plan in terms of what the occlusion looks like. So part of what happens from the examination is we're going to be planning tooth position, we're going to be planning overbite, we're going to be planning overjet. We need to understand that in our examination, we may find some things that tell us as you get to the phase of developing the occlusion, you need to incorporate this into your treatment plan. What are the kinds of things we may find? We may find, in fact, that some of our patients have joint conditions that mandate a certain occlusal position. In other words, we may not be able to use a seated condylar position if we were rebuilding somebody's bite. Certainly not everybody needs to have their condyle seated to be successful, but if we were redoing an entire occlusion, it's a position I use frequently. But oftentimes, in certain joint conditions, we have to realize that that patient may need to be forward significantly to find a comfortable place. So we have to understand that the examination findings are incorporated into our planning process. What are some of the other findings? Airway issues. In 2016, we recognized that airway issues, not just sleep issues, airway issues are becoming a significant issue for dentistry to be aware of. If you had that airway when the patient's in their intercuspal position, that is not where you'd probably want to build this patient's occlusion. Or if you had an edge-to-edge occlusal relationship and you were going to try and correct it by increasing overjet, you probably wouldn't want to extract lower premolars and retract lower incisors on someone who has a constricted airway. It just pops their tongue farther back into their mouth. So what we have to understand is that as we go through this process, there are things that we learn about the patient at the examination and from some subsequent things we might have done for them that will in fact change the actual treatment planning process. We have to incorporate it into the planning process. And what that may mean, for example, is that we may have to consider expansion of an upper arch to allow the mandible and the tongue to come forward, as opposed to retraction in order to create an overjet for some of the kinds of cases we're going to be talking about. Some of the other things that dentists come to Scottsdale with all the time questioning: what about tooth wear? I'm going to be showing you almost every case, well, at least half the cases I'm going to be showing you have tooth wear. So how do you incorporate tooth wear into your treatment plan? How do you know that what you do is not going to end up looking like what they have? And part of the answer is you have to learn to look at tooth wear differently. When we teach occlusion, basically what I teach to students is very simple. Occlusion's a difficult word because it's too big and encompassing. So break occlusion down and make it simple. There's the intercuspal occlusion, that's your bite. There's the edge-to-edge occlusion, that's when you're out in that end-to-end position moving forward, left or right. And then there's the pathways of occlusion that live between the intercuspal position and the edge-to-edge position. So if what you found was a patient who has only wear on pathways, pathway wear is wear on the facial of lower incisors, lingual of upper incisors. If you have a patient who only has wear on pathways, that, and here's an example, this is actually a stone model of a patient, central incisor, that has a significant amount of pathway wear. Notice the incisal edge is not flat at all. The tooth is almost normal length, but the lingual is completely gone. Pathway wear is indicative of a patient who needs more overjet. So in your planning process, once you start developing your tooth position and developing the occlusion, you have to integrate into the plan that this patient is going to need significantly more freedom, more overjet than what a normal patient might need, right? And so if you're thinking about treatment and you're thinking about retracting versus expanding to increase overjet, we typically wouldn't want to, for example, retract upper anteriors in a patient who has this pattern of wear, because we take away overjet. That happens to be the central incisors in the patient you just saw. There's his lower incisors. Note the nature of the wear facets. They're angular facets. They come down the facial surface. They don't go across the top. They come down. Now, in these kinds of patients, the problem is pathway wear patients either have one of two things happen. The teeth erupt to maintain occlusion, or if they have wear in the posterior as well, these patients can lose vertical. That lateral incisor shouldn't be that difficult to restore in a normal patient. How'd you like to restore it in this patient? Why is there no room? There's no room because this patient's anteriors have either extruded as they've worn, or the patient's vertical dimensions closed as they've worn. Now, you could intrude, if the lower incisors had erupted up, you could use orthodontic intrusion to create space and create overjet. In this case, his upper posteriors needed a lot of restorations. He was treated with a full upper arch restoration to open vertical to gain space. The key, though, is this. Here's the final central incisor. Notice the shape of the lingual. Significant freedom. Patients with pathway wear need tons of freedom. And let me back up. That picture on the right is actually that patient, and it's now post 10 years of treatment. He doesn't even wear a bite guard. Patients with pathway wear never break anything. They don't. The only thing they do is they consider to wear themselves if you don't give them enough freedom. But they don't break porcelain typically. Right? What's another very common pattern of wear, especially in dentists? If we took and looked in all of your mouths right now, I guarantee half of you would have this. Purely edge-to-edge wear. Why do dentists have it? Where's your head when you're working? When you do that with your head, where's your occlusion? Sitting out on your front teeth. Like that. Those are the teeth of a dentist. He loves to play on his anterior teeth. So how do you incorporate this into your treatment plan? Pathway wear, you have to increase overjet. What do you do for patients with edge-to-edge wear? He has no posterior tooth wear. He has no pathway wear at all. All of his wear is edge-to-edge. It's very simple. You have to provide distribution of the load, broad, flat contacts. So you share the load so he can slide everywhere he wants. And just so you know, there's really good evidence in 2016. A lot of patients sit out on their front teeth and grind as a method of stress relief. Grinding on your anterior teeth alters cortisol levels and in fact can be very stress relieving for a lot of people. So it may be a habit that's been formed. It may also be a mechanism to try and eliminate stress for all of us. Now, here's his teeth. Look at his lower incisors. You don't see any facets down the facial. All of the wear is just on the tops of the teeth. It's only edge-to-edge wear. Here's what he loves to do. You ask him, what's your favorite place? He just goes right there and he rubs. Now, he wants his teeth to look better. I'm going to treat him really conservatively. So I'm going to just do some composites, just direct composites. So here's my direct composites. I now tell him, go ahead, go back to your favorite place. What happens? It doesn't fit anymore. What's going to happen to my composites if I leave him like this? They're coming off or they're wearing away. So what's the key with edge-to-edge wear? You always have to establish a broad, flat occlusal relationship so people can slide. What does it require? 100% of the time, equilibration of lower anteriors. 100% of the time, the lower anteriors need to be equilibrated in an edge-to-edge position so he can slide all over the place. This is those same composites. They are now 10 years old this year. Hasn't broken them. People with edge-to-edge wear don't break things. They wear them out or they chip them. If it's porcelain, they tend to chip them. If it's composite, they tend to wear them down. Now, who breaks porcelain? Because there are people that break porcelain. People that break porcelain have very specific wear patterns. They are patients that have pathway wear and edge-to-edge wear. They go every place. They go from the outside in, they go from the inside out, they put pressure along the lingual. And in these patients, what you have to do is, if there's pathway wear, you have to give them more overjet for that phase of things. If they have edge-to-edge wear, you have to give them what you just saw a minute ago so that they can smoothly slide. But the biggest issue with these patients is they are incredibly sensitive if you deepen their overbite. In pathway wear patients, you can deepen their overbites, they do fine. Edge-to-edge wear only patients, you deepen their overbites, they do fine. These patients, you deepen their overbites, they tend to break porcelain. And so this is a patient that came in our office. 11 months ago, she had 8 porcelain veneers done by her dentist. In 11 months, 6 of them have fractured. The first fracture occurred 4 hours after the veneers were placed. The teeth are in the way. When porcelain is breaking, the teeth are in the way. She is trying to get them out of the way. Now, here's what's interesting about this patient. The same dentist had done a set of veneers for her 17 years earlier and never had a single one fracture. What was the difference? And the old 17-year-old veneers started getting not very attractive looking, so he told her that they needed to upgrade them. What was the difference between the 17-year-old veneers and these new ones that are breaking? He added length. He added length. Now, here's a model of the 17-year-old veneers. He still happened to have an old model in his office. If we measured the amount of overbite by looking at from gingiva up to central, and now we look at his new veneers, and we measure, that arrow is actually measuring from gingiva to incisal edge of the old veneers that were successful. What's the difference between the new veneers that are breaking? It's only an extra 1.5 millimeters. That extra 1.5 millimeters in her wasn't tolerable, and she's breaking the ceramic. Patients that do that are virtually always patients that have pathway wear and edge-to-edge wear. You can see it in their lower incisors. Now, the problem is she loves the aesthetics of the new longer teeth. So what do we do for patients like this? If she wants the longer teeth, we have to alter the relationship to the lower incisors. It means either opening her bite or intruding or shortening lower anteriors. In this patient, her lower anteriors were up above the occlusal plane. In this patient who is in her 60s, she chose not to do orthodontics. We're going to equilibrate her lower incisors 1.5 millimeters to allow us to, in fact, replicate the overbite she had with her old veneers with new ones that are the length she likes. And that's what it looks like after equilibrating the lower incisors and restoring the uppers, again, with porcelain, all porcelain restorations, but at the length the previous ones were that were breaking for her. And again, she's over 10 years post-treatment now. So what I want you to realize is as we go through all these cases I'm about to embark on, all of these factors get put into them. So when we see pathway wear, it alters our occlusal planning. When we see edge-to-edge wear, it requires a specific occlusal plan. When we see edge-to-edge and pathway wear, it requires a specific occlusal plan. If we see airway problems, it tells us we can't retract people, we can't lock them in. We can't take teeth out and pull them back to correct occlusal relationships. We need to use expansion. All right. So bottom line is, how are we going to start this process? Well, we're going to start with aesthetics. We're going to start with tooth position. And so what's very helpful is to identify what we might consider as normal, ideal, acceptable tooth position, both aesthetically and functionally. So I'm just going to use this attractive young woman as an example of quickly kind of the parameters of what I would call normal. And there isn't an ideal. There's a range of ideals that fall within that. But when we start talking about what we might consider as normal or acceptable, typically the things I'm going to be looking at in my planning process, one of my most useful pictures is a lip at rest picture. Easy picture to take. How do you get the patient's lip at rest? You ask them to breathe through their mouth. Open slightly and breathe through their mouth. As soon as they do, immediately their upper lip will go into a relaxed position. What are we looking for? Typically anywhere from 1 to 5 millimeters of central incisor display. It's a pretty broad range. If we don't see any, it usually tells us we need to lengthen the teeth until we at least see 0.5 to 1 millimeter, because if we don't see any, often the patient looks almost edentulous. If we see a lot, and the patient had a gummy smile, it may be telling us that in fact we have the ability to shorten those teeth, move everything up. So lip at rest, there's our normal. Next thing I look at, lip mobility. How far does the lip move from where it was sitting at rest to its highest point? A normal lip will move somewhere between 5 to 9 millimeters. Now recognize that if you had an 11 millimeter central and you were showing 3 millimeters at rest of the central, that means there's 7 millimeters hiding. If the lip moved 7, you'd see the whole central and no gingiva. If the lip moved 12, you'd see the whole central and 5 millimeters of gingiva. If the lip only moved 4, you would only see about 7 millimeters of central and then smile. So we combine lip mobility and how much shows at rest when we think about positioning teeth. In this particular example, her lip moves about 6 to 7 millimeters, which is right within that sort of normal range. What else do we think about in tooth position? You all learned this from your denture days. We think about a pleasing smile line, a level occlusal plane, a nice arch form. Gingival levels, we think about the centrals being the most apically positioned tissue, the central tissue even with each other. Then we go down slightly to the laterals, we go back up to cuspids. What about papilla levels? We think about papilla levels having symmetry. That is, the papilla across the anterior basically all sit in an ideal site, they all sit at the same level. And in addition, we think about the papilla position And what we really look at is what we call contact length and papilla height. And if we were sort of looking at what normal or ideal would be, if we measured from the gingival margin of the centrals down to the tip of the papilla, that would be called the height of the papilla. And research, 3 different papers have done this, and in unworn, well-aligned central incisors, the height of the papilla and the length of the contact are equal. The length of contact being from the tip of the papilla up to the bottom of the incisal embrasure. So that's sort of the aesthetic parameters in a nutshell, sort of the gross aesthetic parameters around tooth position, tissue levels, and papilla levels that we would treatment plan in complex patients first. Now, what do we consider normal occlusally? What's a normal overbite? What's a normal overjet? Is it like 2 millimeters, 4 millimeters, 5 millimeters? So my answer would be this. It's enough overbite to provide anterior guidance and posterior disclusion. In other words, it's enough overbite so when the mandible moves, the anterior teeth take over and the posterior teeth get out of the way. But we don't want so much overbite that the anterior teeth are in the way. So we talk about things like saying if we have too much overbite, we restrict the envelope of motion or the envelope of function. Different people use different language around it. But basically, we want a certain amount of overbite to provide for an anterior protected occlusion in most patients. Now, here comes the interesting thing. To have overbite, because the 4 cases we're going to be talking about, right? Deep overbites without wear, deep overbites with wear, anterior open bites, edge-to-edge occlusions with wear. To have overbite, you have to have overjet. And in fact, overjet is what controls the amount of overbite you end up with. And so when we start thinking about angles, classifications of occlusion, class 1, class 2, class 3, why are they significant? Because they impact the amount of overjet. And by impacting the amount of overjet, it dramatically alters the way anterior teeth erupt and the amount of overbite you either get or don't get. So if we think about a classic angle class 1 occlusion, where the mesial buccal cusp of the upper molars and the buccal groove of the lower first molar, if you have normal sized teeth and you're not missing any teeth, what that does is it creates the correct amount of overjet to get what you and I consider this kind of a normal amount of anterior relationship. Class 1 molar, 2 to 3 millimeters of vertical overlap. That came because of the overjet. It's what allows the centrals to erupt into a pleasing position aesthetically. If we have too much overjet, the centrals tend to over-erupt. If we don't have enough overjet, the centrals under-erupt. We get reverse smile lines. So, we're now going to start embarking on a series of cases. And we're just going to literally use the ones I described. Deep overbites without wear, deep overbites with wear, end-to-end occlusions, anterior open bites. What do we have to assess as we go into these cases to figure out what caused them to look the way they do? And one of the first things we have to assess is their skeletal development. Now, restorative dentists aren't used to that. Orthodontists are used to that. Oral surgeons are used to that. Restorative dentists aren't used to thinking about faces and how to evaluate a face. So I'm going to suggest in complex treatment planning, we need to assess vertical facial development. We need to assess profile development. And we need some facial photographs to do that. And probably the most useful of all of them is the bottom left. Her lips are together, teeth apart. Basically, she's in a resting position. You're going to see in a moment how powerful that picture is to help us, without cephalometrics at all, to help us assess skeletal development. So let's go back to our person we've been using as an example. What I want to know is her face within what would be considered normal and acceptable development vertically? Is it also within normal and acceptable development AP? So what are the things we use? Right between your eyebrows, the little bump between your eyebrows, above your nose, that's called glabella. We're going to put a little dot on glabella. We're going to put a line on the base of the nose. We're going to put a line at the base of the chin. We're going to measure, we're going to call those two arrows together 100%. And then we're going to actually calculate what percent the midface is and what percent the lower face is. A normal average midface will be 45 to 50%. A lower face that's normal will be 50 to 55%. She's right within normal. Why is that important? Because you're going to find that some patients have very diverse vertical facial development, and they may have an anterior open bite. And if you don't see that it's a skeletal problem, you'll be trying to figure out how to correct it, and the answer is you won't be able to correct it unless you correct the skeletal issue. What else do? We evaluate profiles using these photographs. Again, glabella, subnasale, poggia, the most prominent point on the chin, draw lines between the dots. What do we do with those lines? We measure the angle formed by them. Normal facial profile is 165 to 175 degrees. Hers is 170. If your patient has normal vertical facial development and normal profile, but they have anterior relationships like deep overbite or end-to-end occlusions, you will almost never find a case that you would do jaw surgery to fix it if their face is normal, which means your correction will be a dental correction. Okay? So let me show you a couple examples of patients you do need a surgical correction. What you're going to find when you really start looking at patients that have problems, these patients that you make your study models on and you sit and try and figure out what to do with them, if we were to look at the length of a ramus from the head of the condyle to the angle of the mandible, and we said that's normal, you're going to discover that some of your patients have very long ramuses. They are also going to be the patients who typically have very short lower faces. They're going to have very deep bites. They're going to have inadequate maxillary tooth display. You're going to find other patients that have very short ramuses. The patients with very short ramuses are going to have really steep mandibular plane angles. They're going to have anterior open bites or a tendency towards an open bite. They're going to have gummy smiles. And it's all because of skeletal development issues. So as you start to understand that this skeletal development is what's leading to what you and I see as a dental problem, you recognize that some of those problems really need a surgical correction, not a dental correction. And so as I said, the long ramus typically ends up with the flat mandibular plane angle, deep overbite, inadequate maxillary tooth display, the short ramus, steep mandibular plane angle, tendency to an open bite, gummy smile, long narrow face. And so you see this. That's her maximum smile. Those centrals are 11 millimeters long. Look at the shape of her face. Look at that one. They're about as extreme as you can get, going the other direction. If we start analyzing them and we do our measurements, what we start to realize is she has a very short lower face. She has a very long ramus, a very flat mandibular plane angle, a very deep overbite. If we looked at it on a cephalometrics, you can see, in fact, how flat the mandibular plane angle is. Now, aesthetically, you'd say to yourself, well, let's just have a surgeon take the maxilla and just push it down, graft it. But the oral surgeons know if they do that, it doesn't stay there. It's the least stable orthognathic procedure there is down fracturing a maxilla. So unfortunately, they can be treated predictably with surgery, but what it involves is not down fracturing the maxilla, it involves taking the maxilla and tipping it down in the anterior, but leaving the molars where they are. So you break the whole maxilla free, you tip the front end down, and then you go down and you repeat the process to the mandible, which leaves the molars intact, but rotates everything else down. It leaves the attachment to the medial pterygoid and masseter intact, so there isn't any instability. It makes a tremendous difference aesthetically in the face and in the smile. And you'd be surprised how many patients, if they are really conscious and unhappy aesthetically, they choose this. Even though for most restorative dentists, this is like, wow, double jaw surgery, are you kidding? It's extreme. It's actually quite predictable these days. And now if we measure her mid-face and lower face, what we end up seeing is she's right where we would expect her to be, within normal limits. And the biggest difference, look at the smile. Those are the same teeth. Nothing's been done dentally at all. There's been no restorative treatment at all. It's just putting the teeth and the face in the correct relationship. And the other extreme is the patient with the gummy smile. Look at the difference in facial form between these two. The patient you see on the right is a patient who will have a very short ramus and a very steep mandibular plane angle. Often they also have airway issues that accompany this. And often, in fact, the airway issues might have been part of the growth and development issue for that patient. So what do we do for her? She hates her gummy smile. Well, she has nice teeth. She has relatively level occlusal plane. Here's the short ramus. You can see the steep mandibular plane angle. These patients actually are quite amenable to maxillary impaction, which happens to be a relatively stable, actually quite stable procedure. Now, sometimes you have to not just impact the maxilla, sometimes you have to operate the mandible as well, but these patients can be treated very effectively. And I'm showing you these first two patients because I want you to realize that when you see cases in your practice, deep overbites, anterior open bites, gummy smiles, you have to assess facial development, because if that's the problem, there's nothing else you're going to do that's going to impact these patients like this. In her case, the maxilla is going to be impacted. How much? Well, she shows 8 millimeters of central at rest. If you take 8 millimeters at rest, she has 5 millimeters of gingival display. If you were to impact her 5, she would still leave 3 millimeters showing at rest. She'll look terrific. And that's how she was treated. There she is at rest after surgery, and at right full smile, and there's the before and after. And there isn't anything else we have to offer her in that left picture that can get her to the right. We have nothing that can do that. But as long as we diagnose correctly that it's a skeletal issue, which is why it's so important to understand how to look at those facial pictures. Okay. And then the last orthognathic, well, actually, second to the last orthognathic case I'll show you today. So really, when we have inadequate overjet, and we are going to be talking a lot about inadequate overjet during this session. End-to-end occlusions, for example, that's an inadequate overjet problem. When we have inadequate overjet, how do we treat it? The first thing we always assess is the face. And if the face is the problem because it's a skeletal problem, we usually have to consider a skeletal solution. In his case, he's class 3 dentally. We take a look at his face. We put our dots in. We do our measurements. Normal would be 165 to 175. He's 186. He's got a very deficient maxilla. If you combine that, if he had an airway problem, moving his maxilla forward wouldn't just make him look better, it would dramatically impact his breathing and his ability to place his tongue in the right position. Here he is. That's his full smile. He can't show his teeth because his maxilla is too far back. His lip at rest, his teeth are 5 millimeters under his lip. And again, no dentistry is going to be done. Ortho and jaw surgery is going to make him look better. And here's what it looks like after the maxilla has been brought forward into the correct position. And again, what's the big change? You go from there to there. There's no veneers, there's no porcelain, there's no nothing. Just putting the teeth in the right place. When you talk about minimally invasive dentistry, no dentistry is the best, right? And so if you can put the teeth in the right place and get what you want without having to do anything, it doesn't get better than that. Okay, so now let's move on to the ones that are more common in your practice. because those are patients that don't need orthognathic surgery. So we'll start with this one. He's 23 years old. Age 12, he was in a bicycle accident. He fractured his 4 incisors. 3 of them were devitalized. He's now age 23. He wants to look better. And his mother's a patient of mine, and she actually brought him in and said, can you make my son smile look better? Doesn't look very good. Class 1 molar relationship, he does not have any discrepancy or minimal discrepancy between a seated condylar position and his intercuspal position. Why is that something we look at? Because when patients have end-to-end occlusions, and he does, he has an end-to-end anterior relationship, sometimes you can gain enough overjet just by repositioning the mandible into a seated condylar position. He doesn't have any shift, so that's not going to happen. Okay? He has 0 posterior tooth wear, and he has virtually no restorations in his head. So we're not going to want to do much dentistry on this young fellow. Now, his facial development, if we measure everything, you're going to see is quite normal. You'll see the photos in just a second. So here's our problem. We want to lengthen his 4 incisors because they're about 2 millimeters short, but I can't. The lower incisors are in the way because of the end-to-end occlusion. So lip at rest, he shows about 1.5 millimeters. If we added another 1.5 millimeters to 2, he'd be at 3 to 3.5, which would be pretty normal for some young 20-year-old. You can see where his canines are and his premolars. You can see if we add again 2, it'll be a nice pleasing smile line. His lip mobility right within normal limits. This is a really easy case aesthetically. If he had no lower teeth, this would be a really easy case. Right? Don't you feel that way oftentimes? If your patient didn't have any lower teeth, you could make them look great and they'd never break the porcelain either. Right? And so now we do our assessment, we put our dots in the right place, and we realize, wow, totally normal profile, totally normal vertical development. This is a dental problem. He's got a class 1 molar relationship. This is an easy dental problem. This is a problem of his anterior teeth. It's all related to what's happening in his anterior tooth position. Because everything else is good. His posterior occlusion's good. His posterior teeth are fantastic. He just has a problem with tooth position. He doesn't have enough overjet. So there's your algorithm for how you gain overjet. You either procline upper anteriors, you retract lower anteriors, you intrude upper incisors if they have worn and erupted, you intrude lower incisors if they've worn and erupted. If it was a skeletal problem, you could do orthognathic surgery. If in fact it was a case like the one I showed you earlier where you have to add 7 millimeters to the centrals and open the bite, yes, you can gain overjet that way as well. So effectively, if we would have seen this young fellow, probably when he had the accident when he was about 12 years of age, he's been like this probably since he was 16, 17, 18 years of age. How do you gain overjet in this? Here's your choices. You either have to do this out, which allows you to come down, or you have to do this, retract, which allows you to come down. Those are your choices. If you need overjet, you only have 2 choices. You either got to bring the lower back or you got to take the upper out, or a little bit of both. Those are your choices. And so as we go through our treatment planning of where we want to put everything, it's quite simple. That's what I want to do. That's my aesthetic treatment plan. That part's easy, right? I look at the inclination. Do I want to procline the teeth? Here's how I do it. I don't take cephalometrics because I don't need them to do what I do. Instead, the way I evaluate tooth inclination is I draw a line along the occlusal plane, I draw a line along the labial surface of the central, and I measure that angle. And by the way, this is all so easy on a computer. It is like so easy. You just draw the lines, and literally you click on each line, and it tells you the angles it's sitting at. You can do the math. That is almost perfect. 85 degrees to 90 degrees is almost a perfect inclination of the centrals. I don't want to procline those teeth. They're right where they should be. Gingival levels. Do I think these teeth have erupted? What would they have looked like had they erupted as they had worn? We would have seen the gingival levels on the centrals and laterals significantly coronal to the cuspids. That's not what we see. The gingival levels look terrific. It doesn't look like these teeth have erupted at all. Lower incisor position. I can tell you, if I don't want to procline the upper teeth, and I'm not going to intrude them because they haven't erupted, I can promise you the problem is the lower incisors. You don't need the ceph to know that. If everything in the maxillary arch is in the correct place and you have no overjet, the problem is the lower incisors. Now, if you're an orthodontist, you take a ceph. What do you typically look at? Where is the labial surface of the lower anteriors relative to bony chin? A typical reference for an orthodontist is that line right there. What is normal typically? Even with bony chin or a millimeter in front of bony chin. Where are his? They're 3 millimeters in front of bony chin. What happened to him after he fractured his upper anteriors off? It appears the lower anteriors have proclined on him. What's going to be our treatment in order to get overjet? We're going to retract the lower anteriors. And I want you to notice at the back of that ceph, you see that big open airway in the back of him? He's not a patient you're going to worry about retracting lower incisors on at all, right? Now, Vince Kokich Sr., who was the orthodontist I worked with for 30 years, was doing the ortho in this case. Vince needs 2 millimeters. That'll get me enough overjet. How do you get 2 millimeters? You have to create 4 millimeters of space. For every millimeter you want lower incisors to come back, you have to create 2 of space. And sometimes it involves taking out a tooth. Sometimes it involves stripping teeth. In this case, Vince used a 0.5 millimeter diamond disc and took a 1/4 millimeter from the embrasures of each of these teeth, which gave him about 4.5 millimeters of total space, and then he retracted the teeth. Now I have adequate overjet. I can come in. Those are my 4 provisional restorations on the incisors, and here's the case. As I said, this is not a hard case at all. This is about 6 months worth of orthodontics, stripping and retraction, get overjet, restore, done. But what I want you to get out of this is that end-to-end occlusions are overjet problems. Most restorative dentists think end-to-end occlusions are vertical problems. They're not. Unless there's wear on back teeth. If you have unworn posterior teeth, you can't lose vertical dimension. So if you see a patient with beautiful posterior teeth, it's not a vertical dimension problem. It's an anterior tooth position problem. Now, let's go to a little bit more difficult patient. Maxillary anterior tooth wear, mandibular anterior tooth wear, 0 posterior tooth wear. His posterior teeth are phenomenal. His anterior teeth look terrible, right? He's class 3 dentally. So he has a class 3 molar relationship. He has a class 3 canine relationship on the right. He, again, has no centric relation to intercuspal position shift, so we're not going to get any overjet by putting him back. Very little posterior tooth wear, and if we look, his face is very normal. So let's treatment plan him. Most dentists look at this case and think, I have to do a rehab, open his bite, and treat 14 or 28 teeth. And you say to yourself, well, my patients aren't going to do any of that. I'm just going to watch him. And so these cases tend to just live in offices, never getting treated. Once you learn how to diagnose this patient, you're going to be shocked to see he is going to be treated with 6 total restorations before this is done. 6. Right? Now, what's the challenge of a class 3 molar relationship? There's no overjet in the anterior. And so when you have a class 3 molar relationship, your anterior teeth can't erupt correctly. They're going to erupt end to end or full class 3. So what's the problem of just leaving him like this and restoring the teeth? What's the problems of an end-to-end occlusion? Well, one of them is aesthetics, because most end-to-end occlusions have reverse smile lines, unless they've worn the whole arch flat, which he doesn't. He has a reverse smile line. His canines are significantly down, and his canines and premolars look terrific. His four incisors are short. So aesthetically, if you restored these teeth like this in this position, they don't look very good. Number two, edge-to-edge wear. If you restored them and leave him end-to-end, those patients do have a tendency to chip edges. So you really have to do what I showed you earlier, where you make really broad, smooth occlusal relationships so they can just slide all over on them. Most patients with edge-to-edge anterior occlusions risk wearing out their back teeth, because when you have no overbite, you have no anterior guidance. He happens to somehow posture forward when he does what he does. He's not wearing out his premolars and molars almost at all. And then some patients end up with some muscle issues because of the lack of anterior guidance, but honestly, not many. So what do we evaluate? All the same things we're just talking about, except I'm going to add a few for you. When you see an end-to-end relationship, the first thing I do is vertical facial height. Second thing I do, soft tissue profile to see if there's any skeletal problems. Third thing I do, molar relationship to see is it class 1, class 2, or class 3. Fourth thing I do, count teeth. Oftentimes you end up with an edge-to-edge relationship because the upper arch is short because it's missing teeth, or the lower arch is long because it has retained primary molars or maybe even a supernumerary tooth. So let's just walk through our assessment. Put the dots on his face. Normal vertical, normal profile. This is not going to be a jaw surgery case. Even though he has an end-to-end occlusion, it is highly unlikely this would be a jaw surgery case. What would be the only time I would probably tell you it would be? If he had an airway problem as well. If he had an airway problem as well, it would be much more likely you would advance the maxilla to try and open up space for the tongue, as opposed to considering retracting anything in the mandible. He's missing one lower incisor. If he wasn't missing that lower incisor, he actually wouldn't be full end-to-end. He would be much more class 3-ish looking than he actually is. You can see the wear on the incisors relative to the posteriors, right? So most likely, when he was 18 years old, he never looked like this. We would like him to look like this, but he probably never looked like that. He never had a normal envelope of function, never a normal overbite relationship. When he was 18, he probably looked like that. Now here's the problem. What's happened to him? As he has done whatever he's done, for whatever reason he's done it, he's caused this wear, but the teeth don't sit like that. Instead, they do this. And then he keeps going. And finally, he gets to be 50 years old and he shows up in your office looking like that. And he says, I want my front teeth to look better. And he brings you his high school picture. Look how good my smile used to look. And you go, yeah. Now you look at it and you think you need to open the bite. No, his back teeth are fine. What's the problem? The problem is the anterior teeth have erupted. And as they've erupted, they've brought tissue with them, and as they've erupted, he's lost overjet. What do you need to do to treat this patient? You need to take that upper central and do that. You need to take the lowers and do that, followed by that. And all of a sudden, you can treat him by treating his anterior teeth. You don't have to touch any other teeth. And so if we go through and we look at our diagnosis, let's figure out where to put the centrals first. Normal lip mobility just barely shows the edges of his centrals at rest. You look at the canines, you look at the premolars, I would guess we're going to put the centrals about there and the laterals about there. Okay? Now back up for a second. So if that's the treatment plan aesthetically, which is what we always have to do first, if that's the treatment plan aesthetically, unless we're planning on bringing these teeth way forward, right? So let's figure out, are we going to bring them way forward? Yeah, we're going to procline them a little bit, but they already are starting to look a little bit on the procline side. But I will tell you, when you need extra overjet, if you're going to do some ortho, yeah, you'll fudge on that, and you probably will bring them out some. What are we really going to have to do to this patient if we want overjet? We got to take his lower incisors back. Just like the previous patient, just way more. A lot more than 2 millimeters. Right? Are we going to intrude the upper incisors? How do we decide whether we intrude teeth or not? Typically by looking at gingival levels. You look at where you want the incisal edges, and then once you get that, you measure width and length, and you realize you have a very square tooth. Even with the correct incisal edge addition, it's a very square tooth. I'd like the width to length to be somewhere between 75 and 85% for most of these patients. And so we say, okay, where do we probably want the tissue? We probably want it up around there. In this case, if we did that, that gives us a width to length ratio on both centrals of about 80%. So yes, if we're going to treat him with ortho, we will intrude and procline the teeth. Now, we could accomplish the same gingival position without ortho. We could do it with crown lengthening surgery. Unfortunately, though, it won't give us any overjet. Right? What are we going to do with the lower incisors? Have they erupted up? Yep, a mile. So what would we ideally like to do with the lower incisors? We would like to intrude them down. Now again, if we didn't do ortho, we could crown lengthen them to move tissue and bone down, but it won't give us any overjet. And so we kind of have a clear picture of what we would like to do, and what we're not going to do is we're not going to do orthognathic surgery. And his posterior teeth are great, so we're not going to open his bite. And so what we're left with is an understanding that really what happened to him, his back teeth didn't change at all. What happened is he wore his anteriors, and the anteriors erupted. And we're now left with, what do we do with that? So, what if this patient says, but I really don't want to do orthodontics? Which, by the way, every adult patient I know says that. Every adult patient says, I don't want to do orthodontics. I want you to understand, to me, that doesn't mean they won't do orthodontics. That just means they don't know it yet, right? It's like people will say things to you like, well, my budget's $1,000. No, you just think your budget's $1,000. The only reason you think your budget's $1,000 is you don't know yet what's possible. It's like when you and I go shopping for a car or clothes. I go shopping because I want a new shirt. And I end up with a tie, belt, and a pants to go with it because the salesman said, well, look, that shirt would look so good with all of this. You're right, right? And so what you have to do is make a compelling case for why you would do orthodontics. What's the compelling case? If I don't do orthodontics, in order to make you look good, I need to lengthen your upper teeth. The only way I can lengthen your upper teeth is I will have to do surgery to move the gum tissue where it belongs, but I still can't lengthen the teeth to the right place without opening your bite. I will now have to treat 14 teeth to do that. So I will open your bite and I will treat 14 upper teeth. By the way, in order to make the lowers look good, I will also have to do crown lengthening surgery there and do that. So for 17 restorations and surgery on the upper and surgery on the lower, I can make you look better and you still won't have a very good occlusion. Oh, but by the way, if you did orthodontics, I can actually treat 4 upper teeth and you'll see in a minute only 2 lower teeth, and you'll look great and you'll have an ideal result. Or you can do 2 surgeries and 17 units and have a compromise. What would you prefer? It's like that's how you get people to understand why it's beneficial to do some of the things we want them to do. Right? In his case, he's willing to do it. Vince Kokich is the orthodontist again. Vince is going to extract 1 lower incisor, retract teeth, and as I said, in 2016 in a case like this, if we thought that there was an airway component, we probably would have considered not taking out that tooth. We might have even expanded the lower and we would have moved the maxilla forward. airway involvement's definitely changed the way we treatment plan a lot of these. This fellow has been treated for years. He's done extremely well just like this. So why are we only going to have to do 2 restorations on the lower? Because we're taking out 1 incisor. And he only has 3 worn incisors. The cuspids are okay. How about the upper? We're going to intrude and procline and restore 4 incisors. So this whole complicated case is going to literally be ortho and 6 restorations. Because the ortho will put the teeth in the right place. So here's what it looks like as the upper teeth get intruded. And what's Vince doing? Vince is looking at gingival levels. He's trying to get the gingival levels on the 2 centrals even with the canines. In intrusion cases, it usually takes about 6 to 9 months to get them to here. And then the brackets come off. I'll direct bond them. We don't try and get fancy with the bonding because they're just going to put brackets right back over it. So it's just 1 shade. It's no elaborate final composite restorations. It's just get the tooth in the correct length. So that's what it looks like when it got sent over. Vince has taken the brackets off the lower incisors. He's taken the brackets off the upper incisors. It gets sent over for direct bonding. Now we direct bond the teeth. Vince puts the brackets back on. And here it is at the end of ortho. What's the beauty of the composite? You get to test drive the occlusion. You test drive the overbite and overjet for at least another 6 to 9 months. If there were any problems in the occlusal relationship, it would show up in what he did to those composites. There he is after the brackets come off. Porcelain veneers on 4 incisors, porcelain veneers on 2 lower incisors. And honestly, this is a case you could just as well have just done final composites and not converted to porcelain. This patient chose to do the porcelain. What I want you to get out of this is look at the left picture. When you see the left picture, how many people think this case is going to be treated with 6 restorations? Most people look at it, most restorative dentists look at it and go, that's a full health, that's a rehab, that's a complex case. No, it's a tooth position problem case. As soon as the tooth position's corrected, it's not a complex case. It's just like all the other cases you treat. And that's what he looked like aesthetically when it was done. Okay. Now, we live in an interesting orthodontic world in 2016 in a couple ways. One, because of our awareness of airway issues, and I put airway/sleep only because a lot of people think of it as a sleep problem, sleep apneic problem. But there are a lot of people who have airway problems that aren't apneic. And they can be very much affected by us restricting space for the tongue. So I'm going to show you an end-to-end occlusion case treated in a more contemporary way orthodontically. Here's the patient. She is end-to-end in the anterior. She's got a class 1 molar relationship. She's got crowding in both arches, constricted arches, recession on some teeth, and I can promise you this case traditionally would be treated with some extractions. In order to align the teeth, the traditional way of treating this patient orthodontically would be to consider some extractions. It's difficult, look at all the recession, it's difficult to think about taking a patient like this and expanding because you're worried about the teeth moving right out of the bone and tissue. But it's a different world today. She's been diagnosed with upper airway resistance syndrome. What happens for her is she doesn't get apneic. Instead, her oxygen saturation levels go down slightly because her tongue drops back multiple times during the night, and she wakes up agitated with her heart racing. So she doesn't sleep well at all. Really constricted arches. How's she going to be treated? She's going to be treated orthodontically with no orthognathic surgery, but using a very different approach than traditional ortho. Everything's going to be expanded. So there's the arch form in the maxilla and the mandible pre-treatment. There's not going to be any extractions at all. And I'm sure many of you have heard about orthodontics. Some people call it periodontally assisted osteogenic orthodontics. Other people prefer to call it surgically facilitated orthodontic treatment. That's how a lot of these cases of ours are being treated these days. This patient, periodontist flaps the entire case, wounds the bone, particulate graft, alloderm over the top. The wounding will accelerate tooth movement for about the first 4 months of treatment because it removes the hyaline from the periodontal ligament space much faster than conventional ortho. Bone grafting allows you to have a much thicker periodontium to move into. And soft tissue grafting, again, much thicker soft tissue. You already have a patient with thin periodontium. The surgery was done by Mike Curry. This is a friend of mine's case, beautifully done. Rick Robley, an orthodontist in Fayetteville, Arkansas. Mike Curry is the periodontist who did the surgery. Here it is sutured. Rick does an incredible amount of complex ortho with Invisalign. Rick has done entire maxillary intrusions with Invisalign, using mini implants, doing the surgery first, literally connecting the Invisalign trays to elastics and impacting posterior maxillas. Amazing stuff he's done with Invisalign. So there's pre-treatment, and here's the same patient 9 months post-treatment. And if you're a patient whose tongue is looking for space, you just found a massive amount of more space because everything got expanded to make space. Same thing on the lower. And in the process, he was able to take her from the end-to-end occlusal relationship and put her into a normal occlusal relationship, overbite-overjet relationship. Okay? And of course, some of the other added benefits are dramatically improved aesthetics. So that's sort of a 2016 methodology for treating end-to-end occlusions using an expansive process instead of an extraction and retraction process. It's not everybody needs to have this done, but people who have airway considerations benefit from having it done. All right, let's go the other direction. Those were end-to-end occlusions. Let's go to deep overbites. We think about deep overbites, we'll start by thinking about class 2s. Class 2s have deep overbites. Why? Because they have too much overjet. And when you have too much overjet, that happens. You get over-eruption of the upper anteriors, over-eruption of the lower anteriors because the teeth don't run into each other because there's too much overjet. So now you take this patient. She doesn't like her smile. She's got a little bit of a gummy smile. The anterior teeth are hanging down. Some of the risks of a deep overbite. Aesthetics is a big one because of over-eruption. Some people get pathway wear because they get restricted. Some people get mobility or migration because of the restriction. Some people get lateral pterygoid pain. So, same things, right? Same exact parameters we have to look at. Facial development, etc. So let's look at her face, put our dots on there. Her profile's a little bit flat, certainly not class 2-ish looking at all. Her vertical development's perfectly normal. And yet we have this incredibly deep overbite. So where in the world did that deep overbite come from? Well, it looks like it's because she's skeletally class 2. But her face is saying, no, she's not skeletally class 2. Where did it come from? Where did the excess overjet come from? She's missing first molars. What happens when you lose your lower first molars very early? You get a short arch. What happens when the lower arch is too short? You get too much overjet. You get too much overjet, what do the upper teeth do? They come down. Lower teeth go up. So, that's what she doesn't like. She doesn't like that appearance. You can see very clearly that the lower teeth, in fact, have erupted much more than the upper teeth. The dramatic change in the lower occlusal plane. So if we were to treatment plan her, central incisor position first, she's got a ton of central at rest, and remember, all we're doing is we're establishing where the upper teeth should go first, and then we're figuring out how to make the occlusion work. I mean, that's basically what we're doing. She shows a lot of upper central. She has normal lip mobility. If we were to identify kind of what we'd like to do for her aesthetically, it's pretty simple. We'd like to take the upper anteriors and intrude them about 3 millimeters. Simple treatment plan. Now, if we looked at the lower anteriors and we said, what would you like to do to the lower anteriors? Oh, probably that. And you go, there you go. There's the treatment plan. Let's get her to the orthodontist. There's just this one problem. The reason she looks the way she looks is when she was 16 or 17 or 18, she looked like that. And everything erupted like that. And now what's going to happen if we have the orthodontist level the upper arch and level the lower arch? We end up with that. So the challenge in these cases is quite simple. If you send her for orthodontics, the orthodontist is either going to have to decide to take something out on the top and pull the uppers back, or they're going to have to do something to allow them to move the lower forward, which is very doable. The retraction's probably not what we want to do. We probably don't want to take upper teeth out because her problem is she's missing some lower teeth. Now comes the reality. She's one of my best friends. I see her all the time. I've known her 30 years. She has no joint issues, no muscle issues, minimal wear. She's 63 years old. She looks at me and says, I'm not going to go. Why? I'm 63. I just don't want to show as much gum tissue when I want prettier teeth. She says, I don't want orthodontics. You know what? I couldn't make a compelling reason for her to do orthodontics. So what am I going to do? I'm going to make it look like we intruded the upper teeth. But I'm not going to intrude the upper teeth. What did I do? I crown lengthened the facial of the anteriors about 3 millimeters. Those two arrows are the same length. That'll give you an idea of how much crown lengthening was done in the facial. And we're going to shorten the incisal edges. But in reality, we're not moving the teeth. The lingual is staying the same. The occlusal relationship staying the same. Deep overbites are not always bad. They're not hurting her at all. In her case, it just is the aesthetics she wants changed. And then she did want prettier teeth. This is one where I did put veneers on there after the crown lengthening and after the shortening. And we go from the left screen to the right screen without really any occlusal change at all. Because you know what? An end-to-end occlusion by itself is not bad if there's no symptoms. A deep overbite by itself is not bad if there's no symptoms. We don't need to treat patients to an ideal occlusion unless they actually have problems with the existing occlusion. In her case, it wasn't an occlusal problem, it was an aesthetic problem. And, you know, oftentimes it's hard to visualize what some of these cases look like in the patient's face. So my wife and I happen to have dinner with she and her husband fairly often. So this is her about 2 weeks ago at dinner. Probably gives you a better sense for what the teeth actually look like in her face. The cat down below didn't like me, apparently. You know, I don't know, can you have cats on a dinner table in a restaurant in England? Yeah, I didn't think so. We live on a little island north of Seattle. We're pretty liberal up on our island, so it's okay to have the animals wandering around the restaurant. Okay. Now, if that patient would have done ortho, remember she was missing lower molars. That's how she ended up with the excess overjet. If she would have done ortho, what would it have looked like? Would have looked like this. This is a patient missing lower primary molars. She's a young female. Look at the excess overjet. Her lower incisors are occluding on her palate. I don't know about you, but I don't want to see a 20-plus-year-old person and at 20-something, her lower incisors are already in her palate. Because you go, well, what's that going to look like by age 40, 50, 60? So yeah, this is a patient I don't want to leave this way. How did she get this way? She got this way because she's missing lower premolars. So that previous patient, had she been willing, this is what happened to her. When you're missing a lower tooth, your arch is too short. When your arch is too short, things erupt. In this particular patient, what we're going to do is open the space for the premolar, intrude those over-erupted incisors, put in an implant, and boom, everything gets better. And look at that bony chin. Remember what I told you about references? Look how far back those lower incisors are because of the missing premolars. And so I'll go through it relatively quickly. It's simple orthodontics mechanically. Now, what's the risk in doing this? The risk is recession on the anteriors as they come forward, depending on thickness of periodontium, et cetera. What I will tell you is if the teeth are retroclined, it usually is not a big risk. But here, Vince Kokich pushed the teeth forward, single tooth implant. Look at the anterior relationship now. Remember, those lower incisors used to be in her palate. Look how nice the occlusal relationship is now. There she was pre and post, right? So yes, we can expand lower arches. There's no question we can expand lower arches, especially if they're the way they are because somebody's missing teeth, right? I'll show you one more contemporary one, just again, so you get a sense of what's possible in 2016. Patient who is 4 bicuspid extraction case, very retroclined upper anteriors, very over-erupted upper anteriors, very constricted arches. Again, a difficult case for conventional orthodontics. This is Rebecca Bachau, who's the orthodontist that we use in Seattle now. Rebecca's trained as a periodontist and an orthodontist, so she does her own surgeries for these cases. She's going to take that upper arch, expand it, and intrude the uppers. She's going to take the lower arch, expand it, and intrude the lowers, and that's how she's going to solve the overjet problem. She's going to procline those lower anteriors way forward in the ortho. So here she is pre-treatment, puts everything, the appliances on, does her surgery to create the wounds. Same thing on the bottom. And the shocking thing is how much they get done so quickly in these cases. That's probably 6 months, 7 months worth of treatment. And here's the patient at the end, which is about 9 months of treatment. So today, orthodontics can really do some amazing things to help us with some of these cases that we see sitting in our practice that we just don't know what to do with. And again, there are also great changes aesthetically for these patients. All right, as we move towards our last couple, I've saved the 2 most difficult cases towards the end. So to me, 2 of the most difficult kinds of patients are anterior open bite cases and deep overbites with pathway wear. If you can imagine, he wants his upper anteriors restored. He wants his lower anteriors restored. There's a problem. They're in occlusion. He's already prepped the lingual of the uppers, and he's prepped the facial of the lowers, and you can imagine the preps are touching each other, right? Because that's effectively what's happening. So what do we do with these cases? We have to diagnose. What? Tooth position first, then occlusion. But we also have to diagnose, is this a skeletal problem? Is he missing teeth? How did he get this way? Right? So he has purely pathway wear. He has no edge-to-edge wear. He doesn't have any what we'd call crossover wear where the mandible goes into extreme positions. So what he's telling us is he needs overjet. He needs a lot of freedom that he doesn't have. And there's no way you're going to give a patient freedom by trying to prep and put porcelain in there. It's not going to happen. So let's go through his assessment. And when we think about his assessment, it's the same as everybody else's. We'll put in our dots. And in his case, he's just about perfectly flat. So if you look at him, 46-54, his vertical dimensions are good. His profile is just about 179, so it's a little bit flat. In reality, again, you think about it and you add in the fact he's dentally class, his molars are class 1, this is not a case you're going to think about jaw surgery to correct. It's just not. Anybody that has an acceptable profile and a class 1 molar relationship, well, that's a rare case to think about doing jaw surgery on. Unless there's been problems of isolated areas of an arch, like a missing lower molars and maxillary molars erupt down. You do a segmental osteotomy, something like that. But this is not a case we typically think of as a jaw surgery case. So with that behind us, what does that tell us? It's an anterior tooth position problem. He looks the way he looks because of his anterior tooth position. His molars are great. He has no wear on his molars at all. He's got an acceptable face, class 1 molar, no wear on his molars, no centric relation intercuspal position shift. This is an anterior tooth position problem. So when he was 18, I promise you he never looked like that. We'd like him to look like that, but he never looked like that. He never had sort of a normal inclination of the upper anteriors, lower anteriors, normal overbite. He never got to see what it was like to have a normal amount of freedom. Instead, when he was about 18, he probably looked like that. Probably had retroclined upper anteriors, retroclined lower anteriors, a deep overbite, potentially from intense muscle pull. And the trouble is that inclination can really restrict your freedom of movement. And so then what happens? You, for a number of different possible reasons, you start to do that and you wear out your teeth like that. But they don't sit like that. They do that and they do that. And then you keep going. And now he shows up at your office. And he says, you know, my lower teeth don't look very good anymore, and my uppers, I think, are getting pretty thin. I want to do something with them. And you get alginate impressions. And you take them back and sit at your desk. And you're going, wow, I have no idea. I have no idea what to do with this guy. And if you had the photos so that you could realize that in fact his face is normal and he has a class 1 molar relationship and his posterior teeth are perfect, you realize your answer lies in how to correct the position of those teeth. And the answer looks like this. The upper anteriors have to do that, and the lowers have to do that. And if you do that, you can make him look like what you would have liked him to look like when he was 18. Now, let's walk through our possibilities. There's our little algorithms, okay? Where's his incisal edge right now? It's even with his lip at rest, so we're going to want to add some length to it. And notice we're always starting with the centrals. We're always starting with where do we want to put the upper anteriors and then the upper posteriors. In his case, we probably want to add about that much, right? Now, do we want to procline the upper teeth? Yes, we definitely do, right? These things are way retracted. We want to bring them way forward. Remember pathway where he needs overjet. We want to bring them way forward. Gingival levels, does it look like the teeth have extruded a lot? Honestly, not a lot. Lower incisor position, do we want to like pull them back? No, look where they're at relative to the chin. They're already way back. Granted, this guy has a strong chin. Now, what's the real problem with lower incisors? And I'm going to show it to you on this radiograph, but you could see it if you could see his face. His real problem is his lower incisors have erupted up a mile. That's his resting lip level. When he is in his lip at rest picture, his little short lower incisors are sticking up 4 to 5 millimeters above his lip. He's got massive lower anterior over-eruption. That's why he has the deep overbite you see. He's got retroclined upper anteriors and massive eruption of lower anteriors. So, treatment plan. Procline the uppers, yes. Retract the lowers, no. Are we going to intrude the uppers? Yeah. The incisal edge being correct, the teeth are still too short, so sure. As the teeth are proclined, they'll get intruded some. About to there. So there's our upper treatment plan. Now comes the interesting part. Look at the lower incisors. Some people will say, why don't you just open his bite to get room? All right, let's restore the lower incisors to a normal space, and I want you to look at their gingival margins. The gingival margins on the lower anteriors match the posterior occlusal plane. Does that tell you how much they've over-erupted? If you wanted to try and open his bite, how long would you have to make the molars to have a level occlusal plane? In patients with massively over-erupted lower anterior teeth, opening vertical dimension is never a good option, ever. You have to resolve the over-erupted lower anteriors. Right? Now, that's where we'd like these teeth to be. That would require ortho. What if he says no? What if he says no to the ortho? I'm not going to do the ortho. Maybe I can't make him see things the way I see things. So here's your other choices. Crown lengthen the lower anteriors, extract the lower anteriors, or extract and place implants in the lower anteriors, right? So look at the lower anteriors where they would be now. All right, if you took them out and did implants, the implants would need to be there. When most people extract teeth, where do you put the head of the implant? Level with where the crest of bone is. If you extracted the teeth right now, where's the crest of bone? You can extract these teeth and put implants in as a solution, but you're going to have to take the bone down to there. Otherwise, you're just trading over-erupted teeth for over-erupted implants. Right? In his case, what did he do? He did the ortho. Right? Not going to do jaw surgery. We're not going to change his vertical. Now, here's the interesting thing. If he wouldn't do ortho, you almost have to take out his upper teeth, upper incisors. Here's why. That's what we want his tooth position to be. On the left is what his tooth position is. Combine the two of them. Imagine trying to prep so that you could restore the tooth to be what you want it to be. Now take that away. How much left do you have of what he has if you tried to prep like that? These teeth need to be moved orthodontically. Again, Vince Kokich Sr. did the ortho. The lowers are going to be built up with composite. And here we are post-treatment. The build-up teeth are now level with the occlusal plane. Before, the gingival margins were level with the occlusal plane. The teeth actually intruded 5 millimeters. Some people want to know, how do you know the vertical dimension didn't increase? How do you know posters didn't erupt? This is pre and post Ceph on top of each other. You'll notice the distance from Nasion to Menton is the same. His vertical dimension didn't change. What happened is his lower incisors went down 5 millimeters. And again, this looks like a really complicated case, really nasty. How many restorations did he have done when it was all done? 2 upper central incisor full crowns, 4 lower incisor veneers. The rest is ortho. Just get the teeth in the right place. As soon as the teeth are in the right place, you don't need to do a ton of complex dentistry. All right, last one. Again, one of the difficult ones, anterior open bites. So we've got a 30-year-old, class 3 dental relationship, no CR shift, posterior tooth wear, missing 4 incisors. And you know, we're talking about minimally invasive dentistry and all the things that you were speaking of. This patient saw 5 dentists before she came to me. And you may wonder why a patient would see 5 dentists and keep going from one to the other. She's 30 years old. What do you think in the US the 5 dentists gave her as a treatment plan? All 5 gave her the exact same treatment plan. Full mouth extractions and implants at age 30. She didn't want to lose her teeth. She just kept looking until she found somebody that would do something other than take out her teeth. When I met her, because you look at her mouth, you would never think she would do much treatment. But she had a goal. She wanted to keep her teeth. She wanted a normal bite. She wanted a pretty smile. Now, here's our problem. How do you close open bites? You only got 4 choices. You either have to lengthen upper anteriors, you have to lengthen lower anteriors, you have to shorten upper posteriors, or you got to shorten lower posteriors. Those are your choices. Or you do a little bit of both. How do you know what to do? You go back to the face. The face will tell you what to do. Models will never tell you what to do. That picture right there will never tell you what to do. The face will tell you what to do. So we go back to the face, lip at rest, 3 millimeters of display, 3.5. Lip mobility, 7. Her incisal edge position's nice. Her centrals are in a nice position. But she has a reverse smile line. And I promise you, if you were looking and working off of models, and only models, the temptation would be to do this, to say to yourself, I need to fix her reverse smile line. I'm going to lengthen her anterior teeth down to that line so that she now has a level occlusal plane. And guess what else it will do? It will close my open bite. So I'm going to fix her smile line and close the open bite just by restoring 6 anterior teeth down to the occlusal plane. And you'll be so happy with yourself until you put it in her face. Because when you put it in her face, you now have massive teeth. You would now have 7 millimeters of central showing at rest. You would have 14 millimeter long central incisors with a 62% width to length ratio. What's the correct treatment for her aesthetically? Her anteriors are good. The correct treatment? Change the posteriors. It's just not as easy. So how do you do that? How do you take those premolars that are hanging down, those molars, and get them, that green line is the correct occlusal plane? Well, orthodontic intrusion. We can use mini implants. We can intrude those teeth. Boom, done deal. Crown lengthening. I don't think her roots are nearly that long that you're going to crown lengthen the bis and the molars to that level. Orthognathic surgery, maybe. Remove those teeth and replace them. If the teeth really were in bad shape, yeah, I would consider that. Again, you got things to worry about like sinuses and where can you put the implants, etc. For me, in her case, orthodontic intrusion by far makes the most sense. Except when you close vertical dimension, what happens to overjet? The lowers come forward. When you open vertical, the lowers go backward. When you close vertical, they come forward. She happens to be dentally class 3. When you intrude those posteriors and her mandible closes, what's her anterior relationship going to become? Full-on class 3. How was she treated? She was treated with orthognathic surgery. Move the maxilla forward, move the posterior maxilla up. How far up? To get rid of that. You see the picture on the left? You see the posterior gingival display? That's posterior over-eruption. How much are we going to impact her posterior maxilla? To get rid of that. It's an aesthetic decision. The position of the teeth, the gingiva, the papillas, and the maxillary arch, it's an aesthetic decision, along with airway decisions. There's the models. Model surgery is going to be done. The maxilla is going to go up 5 millimeters in the posterior, and then it's going to go forward into a class 1 relationship. And bypassing 18 months worth of treatment, she's going to go from the left screen to the right screen, and the left screen to the right screen. But honestly, for me, the funnest picture in this case is the before and after of her face. Look at the posterior aesthetics in the maxilla. The difference between those over-erupted posterior teeth hanging down, the reverse smile line, and it's just treatment planning tooth position. It's all about using tooth position and tissue levels and then correcting the occlusion with the lower arch. As I close, I want to acknowledge my buddies of 30 plus years. Vince Kokich Sr. passed away 2.5 years ago, completely unexpectedly. He was like my brother in dentistry. Dave Matthews, the periodontist in the cases you saw. Vince and Dave and I spent 30 plus years practicing together, and it was just the best professional relationship ever. For those of you that are interested in other things that we do, you can go to our website. It's speareducation.com. I've got 250 videos on there, clinical videos, treatment planning videos, prepping videos, seating, bonding, all of those things. We have a total of 700 videos on the site. Very proud of the patient education stuff that we just got done doing. And with that, I just want to say thank you again for the opportunity to be here, and thanks for coming. I appreciate it.